Welcome to The Explainer. Today, we're setting the stage for a highly precise, evidence-based clinical toolkit specifically focused on vestibular migraine. Now, if you're a physiotherapist or a clinician working with vestibular patients, you already know this condition requires an entirely different mindset compared to standard vestibular rehab. We're going to bring some high energy to this today because getting this diagnosis right, it absolutely changes patient outcomes.
This explainer is based directly on the comprehensive literature review titled Vestibular Migraine, Rehabilitation Approaches, Trigger Management, Cautious Dosing, and Co-Management. This entire framework is published by Australian Dizziness Clinics, and you can grab the full document right now at australiandizzinessclinics.com. All right, let's look at our roadmap for today. We'll be covering the vestibular migraine puzzle, the Bárány and IHS diagnostic criteria, VM patient demographics, the trigger wheel framework, and finally, the 2-week symptom diary.
Section 1. The Vestibular Migraine Puzzle.
So why is nailing this diagnosis absolutely critical? Well, vestibular migraine behaves so uniquely, and truly understanding it is the foundation of any successful treatment plan. Think about this for a second. A patient who walks in with 5 episodes of vertigo, a clear migraine history, and photophobia in half her episodes, that's not a diagnostic mystery. She has textbook vestibular migraine. The real puzzle, the one we actually need to solve, is identifying the patient who walks right past us, completely undiagnosed, just because their presentation isn't perfectly classic or because their vestibular function tests come back completely normal.
And make no mistake, this is a massive cohort of patients. Vestibular migraine is literally the most common cause of recurrent vertigo in adults. It makes up 1 to 3% of the general population and a staggering 11% of patients walking into vestibular clinics. To put that into perspective, it's the second most frequent vestibular diagnosis after BPPV and tertiary settings. We simply cannot afford to miss this.
Section 2. Bárány and IHS diagnostic criteria.
Because imaging and standard vestibular function tests, like your VHIT or dynamic visual acuity, are typically normal or nonspecific in these patients, our diagnosis has to rely entirely on patient history and criteria. What you're looking at is the diagnostic algorithm. These are the 4 rigid criteria required by the Bárány Society and the International Headache Society to confidently confirm a vestibular migraine diagnosis. Let's break this down step by step so you can start using it in your clinic today.
Let's build your mental checklist right now. Step 1. You need at least 5 moderate to severe vestibular episodes, lasting anywhere from 5 minutes to 72 hours. Step 2. A confirmed current or prior migraine history, right out of the ICHD-3 criteria. Step 3. At least 1 migraine feature. We're talking a headache, photophobia, phonophobia, or visual aura, and that has to be present in over 50% of those vestibular episodes. And finally, Step 4. There must be no better explanation by another vestibular or central diagnosis.
But hey, what happens when a patient doesn't perfectly check every single box? If your patient meets only 3 of the 4 full criteria, the probable VM label becomes an incredibly useful framework. It relaxes either criteria 1, the total episode count, or criteria 3, the migraine feature frequency. This gives you a fantastic way to appropriately manage patients who are clearly on the vestibular migraine spectrum but just fall shy of that rigid textbook definition.
Section 3. VM patient demographics. Knowing exactly who is most likely to develop vestibular migraine gives us a powerful head start when taking a subjective history. Demographically, you'll typically see a 2 to 3 to 1 female predominance. The onset? Usually in young to middle adulthood, typically between the ages of 20 and 50. But, and this is important, while that's the classic demographic, a family history of migraine is incredibly common, and this condition can actually pop up at any age. Pediatric and postmenopausal presentations are very well documented in the literature.
Section 4. The Trigger Wheel Framework.
So, here is a real game changer. Vestibular migraine episodes are multi-trigger phenomena. They are almost never single-cause events, and understanding this fundamentally shifts how you should be educating your patients. The trigger wheel framework is the absolute foundation of every conversation you should be having in that very first appointment. It elegantly maps out the 6 distinct categories that combine to cross an individual symptom threshold. Let's look a bit closer at the evidence behind these categories.
When we break down the clues using this table, we see some really clear patterns. Sleep regularity, hormonal shifts like the menstrual cycle or perimenopause, and sensory loads such as bright flickering lights or busy visual scenes all have incredibly strong evidence backing them as triggers. On the other hand, dietary triggers like tyramine, MSG, caffeine, and even hydration levels vary wildly by the individual. A blanket restriction diet often just flat out fails. It has to be highly individualized.
Remember, and this is the key takeaway you've got to impart to your patients, no single trigger causes every episode. Instead, it's the accumulated load from these combined categories that finally tips the patient over their unique threshold. It's like the perfect storm. Maybe a poor night's sleep combined with a high sensory environment and a sudden barometric weather change is enough to trigger an attack, whereas just one of those factors on its own wouldn't do a thing.
Section 5. The 2-week symptom diary.
To solve this highly individual clinical puzzle, we have got to track data prospectively right from session 1. Relying on a patient's memory of what they ate or how they slept prior to an episode weeks ago just isn't reliable enough. Here is a massive clinical pearl from the source text, a 2-week symptom diary capturing sleep, food, stress, hormonal events, and episode timing identifies the dominant triggers for roughly 70% of VM patients. 70%. The symptom diary is the absolute highest yield assessment tool we have in the clinic. It easily beats any objective vestibular test for guiding your lifestyle prescriptions and rehab dosing.
Right alongside that symptom diary, utilizing standard patient-reported outcome measures is absolutely critical. We're talking about the Dizziness handicap inventory, the visual vertigo analog scale, the motion sensitivity quotient, and the HIT-6. Because vestibular migraine rehabilitation has a much slower, nonlinear trajectory than standard hypofunction recovery, remeasuring these specific tools at 6 and 12 weeks is exactly how you capture that slow, steady progress.
This brings us to a really critical crossroad. We know that aggressive adaptation drills in a VM patient routinely cause headache flares, photophobia, and dropout. So if standard rehab flares symptoms, how do we safely dose rehabilitation once we've identified the triggers? Well, in part 2 of this explainer series, we're moving to the lifestyle pillars and trigger management. We'll look at exactly how we leverage sleep, hydration, diet, hormonal triggers, and aerobic exercise, which, by the way, is the highest evidence intervention we have in vestibular migraine.
You definitely won't want to miss that. But before you go, ask yourself, how many probable VM patients have slipped through the cracks in your clinic just this month? For additional resources, including the full literature review, the clinical cheat sheet, and the rest of this explainer series, please visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support this series. Thank you so much for learning with us today, and we'll see you in part 2.